And now I'd like to welcome Dr. Richard Shilsky from the American Society of Clinical Oncology, who will moderate our next panel, Supporting Evidence-Based Decision-Making at the Point of Care. As our panelists come forward and take their places, I want to briefly introduce Dr. Shilsky. Dr. Shilsky is a medical oncologist and is also Senior Vice President and Chief Medical Officer at ASCO, the world's largest professional organization representing physicians who care for people with cancer. Dr. Shilsky is involved in professional and patient education, quality improvement, policy and advocacy, communications, clinical research, and the development of Cancer Link, about which we just heard. So, Dr. Shilsky.
Thank you, Ed. And good afternoon again, everyone. I sort of feel like all of the sessions in this meeting have very nicely teed up what we're going to talk about for the next hour in this session, because everyone has been talking about the need for tools. Given the enormous amount of information that is available now every minute of every day to doctors and patients. There are the challenges of how to use that information, how to understand it, how to process it, how to integrate it, and so on, are quite daunting. So we've heard in almost every discussion leading up to now a call for the use of decision support aids and tools that facilitate patient decision-making. It turns out, of course, that there's really no lack of such tools already. There are an enormous number of tools that are in development and have been deployed in the clinical marketplace. And as you think about it, and we've heard many of these alluded to already during the day today, we have, of course, things like clinical pathways, very commonly used now in oncology practice. We have a number of value frameworks, in some and still in various stages of development, not all yet fully deployed. We have tools that have been offered to match patients to clinical trials. We have tools that have been developed to enable matching treatments to the genomic profiles of patient tumors. We have patient-reported outcome tools. We have quality measurement tools. The list goes on. And this morning we heard about a call for health literacy tools as well. So there's all sorts of tools. And one of the challenges, of course, that we now face is how to develop these, how to use them, how to deploy them in practice, how to work them into the physician workflow, and how to integrate information that comes from these tools. And I think importantly, since all of these tools are new and their utility in many cases is not yet well established or proven, we all have some responsibility to participate in evaluating these tools so that we know which ones provide high quality, consistent, reliable information that doctors and patients can use. And this is further complicated, of course, by the fact that oncology is a very dynamic field. The field is not stable and not static. There's new information that's being generated essentially every day. There was information presented just a few weeks ago at the ASCO meeting that was immediately practice-changing. How to get that information incorporated into clinical practice guidelines and value frameworks and other things that already out there is itself a big challenge. So we have a terrific panel, and what we're going to do is I'm going to just sort of briefly say who everybody is, but then ask them to briefly introduce themselves. Each person will make a few minutes of remarks sort of from the particular expertise and perspective that they bring to this discussion. And I'm hoping before we end we'll have some time not only for discussion among ourselves. I noticed that we've got this great audience, but there have been very few opportunities for the audience to actually participate in the conversation. So I'm hoping that we'll have a little bit of time to invite questions and comments from the audience. So without further ado, the participants in the panel from my left to right, or my right to left, I guess, or that way, are Suzanne Bellinson from Blue Cross Blue Shield Association, Deborah Patt from US Oncology. Now, in the program, you see listed Jonathan Hirsch from SciAps. Jonathan unfortunately developed a last-minute conflict and was unable to be here, but fortunately for us, his colleague Sanjay Udoshi is here. Christian Downs from the Association of Community Cancer Centers, and Jennifer King from the Lung Cancer Alliance. So I'm going to turn to you first, Suzanne, and ask you to briefly talk a little bit about what you do at Blue Cross Blue Shield and your perspectives on this whole issue of tools to assist doctor and patient decision-making.
Great. So I appreciate the opportunity to be here and talk a little bit about the work that we do. So we don't create tools. I don't make decision support tools at the association. But my role is Executive Director of Clinical Markets. I work within the Office of Clinical Affairs. And we have traditionally developed evidence-based reviews that have been used by the Blue Cross and Blue Shield plans to make medical policy. 2.5 years ago, we launched a web-based platform that really focuses on bringing stakeholders in the marketplace together to comment on those evidence reviews, to provide new information that can be incorporated into the update of those reviews. And so my place in the discussion of bringing information to the point of care is we develop evidence reviews that are used every day by payers to make coverage decisions. And increasingly, we want to be able to provide that information out into the market so that it can be used more widely and that a common source of evidence can be used to make different decisions in different locales. They can be used by manufacturers in figuring out what information they need to gather. They can be used by providers in building decision support tools for their own practices and establishing good standards of care within their organization. And they can be used by payers and are used by payers today. And the more I think that we can communicate around what types of evidence we want to generate and what types of evidence we want to review, the better we all are. And then we want to be able to deploy that information out to those who are building tools to say, here's a common evidence source that multiple stakeholders have participated in building. Now let's make it available and actionable at the point of care.
Great. So Deborah, you wear many hats.
I do. I'm a practicing medical oncologist, a breast cancer specialist, and I practice about half the time in Austin, Texas. I'm also vice president of Texas Oncology, where we see about half of Texans with cancer. And we work closely with McKesson Specialty Health as a partner, where I serve as the director of analytics. And I have a role in ASCO as the new editor-in-chief of the Clinical Cancer Informatics Journal. So I touch decision support actually in a lot of different ways. And so I'd love to talk about those because I have to say if there's one sort of professional mission statement that I would have, it's how we use technology systems to improve care delivery. And that really means making better decisions that clinicians make, and that means reducing some of that information asymmetry between doctors and patients when patients make decisions, and also involving the whole care team in how we use information systems to improve patient care. So I touch it from a number of levels, and I'll say I think the most meaningful a decision support system that I've worked with recently is, in US Oncology, we've come up with our own system of evidence-based pathways. And so that's a good story to tell because it is a subset of the NCCN guidelines and has a whole process involving pharmacists and physicians, subspecialty stakeholders to develop this pathway system. And that's gone on for a decade, and we've previously published on that it's an effective way to treat patients and that there's cost reductions. But what I've been interested in is the implementation of it as a decision support system. So using it in a web-based format at the point of care, because information systems are really useful, but the end user has to be able to use them to deliver care at the point of care in real time. You can't use them later. You can't come back to them. They can't add time to your day. And so we really studied the implementation of that system across 9 statewide practices over a 6-month period, looking at 31,000 patients, and showed that Our accessible data was much improved, up to 99.5%. Our pathways compliance went up considerably. Our exception reporting went up considerably. And so I think that's meaningful. It's a quality initiative that we know will help to reduce cost and help to improve care delivery for patients by facilitating as a nudge evidence-based choices. You know, doctors always need to be facilitated to do what's in their best interest of their patients when they're in the room with the patients, but we like to be autonomous about that. So that's been a useful endeavor, I think. And then we have other pilots that I'm running a pilot. I'm the PI for a pilot looking at predictive analytics to try to see, can we anticipate individuals at high risk for hospitalization in 30 days and treat them differently? And then we're just starting a study looking at the patient side of that. Can we use information systems to empower patients to make decisions around their treatment? Really, again, to reduce that complex information asymmetry, which I think exists in oncology much more so than other diseases. So I touch decision support from many levels, very interested in the topic, and think it's critical in how we move forward.
Great. So, Sanjay, your company has a platform to really help in the deployment of precision medicine. A lot of precision medicine is very complicated these days. There's lots of data. There's less evidence than there is data. But there's very complex decision-making. Can you talk a little bit about what SciAps does and
Sure.
how you all are thinking about this?
Sure. Thank you all for having me here. My role at SciAps is physician executive, and my responsibility at SciAps is to provide a representation, evangelize the platform in the field with prospective clients. Additionally, align what we are learning from the market with our product roadmap to ensure that we are staying ahead of the needs of our clients, both existing and prospective, and also to work with our client operations group to improve the uptake and usability of the application among existing clients. So a lot of my work is in the field with practicing oncologists, and it's something I enjoy very much doing. My journey in this industry began more than a decade ago, where I was working in health policy research and consulting, providing the reasoning and the financial impact implications of the use of electronic health records. Electronic health records also as a venue for clinical decision support deployment, and the reasons for those kinds of investments. I was then trained at the Geisinger Health System in a fellowship for clinical reengineering and transformation, utilizing basic medical informatics to measure and understand the adherence of our primary care community physicians with evidence-based guidelines. And from there, I was made physician lead for the system over clinical decision support and analytics. I worked for Oracle Corporation as a physician architect over enterprise healthcare analytics, and that's what has brought me most recently to SciAps, where I've been serving over the last 7 months. So what SciAps has done, crucially and importantly, is provide a platform for the integration of next-generation sequencing molecular diagnostic data with the clinical longitudinal record in a unique way that allows for the layering of clinical decision support as well as analytics to be applied to these data in novel ways. And we're seeing that there's also a need for data sharing. There's a need to understand the real-world evidence of how decisions are being made, capturing those decisions and being able to share them and their impact and outcomes with the broader clinical oncology community nationally and even internationally. So we have also built not only a platform for institutions and oncology practices to utilize for the purpose of making decisions around clinical, the impact of molecular diagnostic recommendations and clinical trial recommendations, but also a broad network for all of our clients to share their de-identified data in meaningful ways that will allow them to see changes in practice patterns as we evolve towards a new model of therapy that is acting on genomic variants more and more every day, and choosing targeted therapies and immunotherapies over standard chemotherapy. And we also find that that will evolve new practice guidelines by building a base of evidence that will allow us to suggest and revise and implement existing care guidelines in oncology.
Great, thanks. You brought up a number of points that I hope we'll come back to shortly. So Christian, your organization represents community cancer centers. That's where most patients with cancer receive their care in this country. Lots of information for community-based oncologists to assimilate, particularly since most of them are, quote, generalists and not specialists. What's your perspective on the use of these various decision support tools?
Yeah. Sure, Dr. Shilsky, thank you very much. Thank you to our co-host also for having us, and it's great to be a part of such a distinguished panel. Of course, Dr. Shilsky mentioned ACCC is an organization of about 2,300 hospitals and practices around the country. Everything from large academic institutions to small 1 and 2 doc practices, and believe it or not, those still exist. And in fact, preparing for this talk, I think one of the things I wanted to focus on is what do we do in those 1 and 2 doc practices, those small rural programs, those large urban practices? How do they take information like this and actually operationalize it? Because that's going to be the challenge, I think, going forward. Why are they doing it, and how do they do it? Another unique thing about the ACCC membership is it's very multidisciplinary. So not only do we have in the membership medical oncologists, we also have surgeons, radiation oncologists, pathologists, really anyone involved in the cancer care team. And it's interesting because when you start to look at some of the decision tools that are out there, when I talk to some of these smaller practices and hospitals, they want to see how all of these specialties can be integrated into that, which of course is a tall order. And it's interesting too, because then they say, not only do I want to integrate these physicians, I want to be able to integrate my pharmacist, I want to be able to integrate my nurse, social worker, whatever the situation may be. So that's kind of where I'm interested in how this is going to work and what we need to be able to do to, for lack of a better term, democratize the information that we have, so that that it can get into all of our communities and can support them. And in fact, in many of these communities that we've been looking at, specifically around this area, there are not other alternatives to go to. This isn't a situation, where it's Starbucks or Dunkin' Donuts, where you can say, well, they're closed today, so I can go over here. There's no place else to go. And so I want to be able to make sure we support those institutions, those practices, and make sure that they're able to operationalize this information and these tools in the best format possible.
Great, thanks. Jennifer, I know you have a science background, but you're here really representing the voice of the patient in this panel, in this discussion, and patients have to make some tough choices, as Joan London highlighted very clearly at lunch. Give us a little perspective on whether and how you think these decision aids can be useful to patients.
So I think absolutely the decision aids can be useful to patients. I think we look at it in a couple different ways in our role as a patient advocacy organization. And as Dr. Shilsky said, I'm a scientist by training, but now I run the science department for a patient advocacy group. And we're really always looking at how can tools like this help our patients in our community. So at the moment we're looking, I kind of see it in two ways. First, we have our own program, Lung Cancer Alliance's program called Lung Match, which we view as an overarching patient decision program, of which one component is an online clinical trial matching tool. We've worked with the company who is producing this tool to really look at it from a patient-centric, patient-designed standpoint. So compared to things we had used in the past, instead of filling out a huge online form of lots of different questions about your care, you're posed with one question that says something like, has your cancer spread outside one lung? Now, most patients actually can answer that question, and that question can actually really distinguish whether you're eligible for a large number of trials. And that's an approachable, patient-centric way to look at the question. It then goes on to ask a number of questions, and we've found since we've implemented this type of tool, we're seeing more than 10 times the number of patients each month get all the way through to a list of trials that they can then take back and discuss with their treatment team. So really incorporating meeting the patients where they are and their voice can help in the development of a lot of these types of tools. And we're also finding that we are, as a community, able to address where gaps may be that we need. We had done a more than 800 patient and caregiver survey last year, community needs assessment survey. What are your gaps in care? And interestingly, one of the major things that came out was very low utilization of palliative care, despite very strong data published in the New England Journal about how supportive care and symptom management can actually extend life. And a number of comments written into the what gaps did you have that were not filled types of questions that said, my doctor talked about the treatment with me, and so did the team. No one really addressed the side effects, the symptoms, how to live my real life. Well, now we're seeing, as was discussed in earlier panels, the presentation this year at ASCO, where there's a new tool for patient-reported outcomes, that maybe this can help address this concern that we're seeing in our community. So as an advocacy group, I think we can really underscore the importance of this type of tool, of this type of patient-reported outcome, and also really help the community to think about how to get these tools to the patients and implement them in a really smart way. Because I think for that study in particular, one thing that hasn't been talked about a lot that was mentioned by the discussant at ASCO was that the system itself triggered the alerts when a patient reported that they had a high toxicity symptom. The system triggered the alert to the clinical nurse. And that was based on prior data that if you triggered the alert to the physician, it often didn't get acted upon because there were so many things going on in the physician's day. If the symptom alert was triggered to the clinical nurse, then about 75% of the time, the symptoms were actually being addressed. The communication was effective. So we're really looking at how can these tools enhance communication between the patient and their physician team, and how do we optimize that process?
That's great. That sounds like a terrific tool. It's certainly a lot easier than asking the patient to tell you what their TNM stage is. So that's a great step forward. So I want to begin to drill down a little bit onto some of these points. And I want to start with the notion that I think we all subscribe to the idea of practicing evidence-based medicine. But the question is, what is the level of evidence that's necessary to actually change the way we practice medicine? And where do we get that evidence from? Because unfortunately, we don't have all the evidence that we need from prospective randomized clinical trials, and frankly, we never will. So if we're going to rely on evidence, and we're going to make clinical decisions based on evidence, and we're going to make guidelines and pathways and so on based on evidence, how do we evaluate that evidence and determine if it's sufficient to actually push out to the community to change clinical care? So I'm going to start with Suzanne. You're the expert in evidence evaluation, and get your thoughts on that. But then I'd like to hear from anyone else who'd like to comment about how you think we need to judge the evidence and incorporate it into these various types of tools.
So maybe I'll stick with the how do you judge the evidence part, and then I'll hand off the how do you incorporate it into the tools. I think that, it's been said multiple times here, and I think in other venues, whether we're talking about the totality of precision medicine or we're talking about it specifically as it relates to oncology care, there is a significant amount of data available. There is a significant amount of data that is being generated on a daily basis. And I think the real challenge to us is that much of the data that is being generated and is being proposed to answer some of our large scientific questions is data that is not necessarily or historically the types of data that we have judged to be high quality data to answer questions about efficacy and safety. And I think we are challenged to think about and weigh the benefits and the risks from an organizational perspective about being too cautious in an evaluation or not being cautious enough. And then you have technologies that are being distributed and that patients are being treated with that end up causing harm. So I think we are very, I think, often conservative, but yet I think we're moving in some important directions. So while we continue to have a structure and a probably historical construct around levels of evidence for randomized trials, large observational studies, prospective single arm, right? We have that sort of construct, and we ascribe to that type of construct. I think we also believe that context is incredibly important, and that the context and content of any individual study must really be evaluated in terms of who are these patients, how many of them are there, what's really possible in terms of what types of studies can be accomplished. And then I think the other piece is, particularly in oncology and genetics and genomics now, there is a huge amount of quote-unquote real-world evidence that's being generated. And I think we all as a community need to step back from that a little bit and say, okay, given that we have all of this real-world evidence being created clearly across a continuum of specificity and continuum of quality, what really are the standards by which we want to use this data? And what really qualifies as data that we believe we can use? And what questions are these different data sources appropriate to answer? And so I think that we really do have a responsibility to, I know many of us in this room are doing this work, but to step back from sort of the excitement and the fast train ride of real world data and really put some parameters around it and say, these data are actually really good to answer questions A, B, and C. They may not be so good to answer questions D, E, and F. And I think just understanding that will be a huge step forward.
Yeah, that's a really good point. And at least in my mind, at least, there is and there should be a difference between two terms that are used interchangeably, but I think are actually different. And that's real-world data and real-world evidence. Just because you have data from what happens in the real world doesn't mean you have any evidence. Yeah. And you have to derive the evidence from analysis of that data. And so I think we have to think carefully about that. And again, one of the challenges I think that we all face is how do we begin to use this in practice? We have these sort of camps that exist where the clinical trialists say, well, clinical trial data is the gold standard, and it's the only thing you should rely on. On the other hand, we recognize that we can't possibly answer every unanswered question in oncology with clinical trials, so maybe we need to rely on real-world evidence. And then you have the folks at the other end saying, yeah, but that real-world evidence really isn't very reliable, and so maybe you shouldn't be putting too much into it. And I think we have to get comfortable with the notion that these are complementary types of data. And real-world evidence is never going to be of the quality of clinical trial data. It's not intended to be. It won't be. It can't be. And for those people who demand that it should be, my own feeling is sort of like, get over it and just accept it for what it has to offer. And in the context in which it can be used. But let me ask others who might want to comment. I'll turn to you, Deborah, because I know that you think a lot about these issues surrounding how we should evaluate pathways and what's a high quality pathway and how do we build the evidence.
It's a great question, Rich. So like Susan, I think that you need different levels of evidence for different things. There are different pathway programs, but in our pathways program, and I've directed the breast cancer pathways now for over a decade, so very familiar with our system, we want to use level 1 evidence. We want it to be in phase 3 trials. We want it to be published in the peer-reviewed literature, because sometimes when something is presented, it changes a bit and when it hits publication. And for us, we want it to be part of NCCN guidelines. But I'll say that, again, it's a nudge. It's not saying that 100% of patients have to be treated within these guidelines. And so we think that it should be around 80% of patients that are treated within those guidelines, because clearly there are reasons for reasonable and warranted variation from guidelines that the level 1 evidence in peer-reviewed phase 3 clinical trials that hopefully demonstrate a survival benefit may not include all of. And I think we've all had pianists and harpists that maybe already have some diabetes and peripheral neuropathy that maybe shouldn't see paclitaxel, and we need to think about their chemotherapy for risk reduction differently. We have the breast cancer that has a rare phenotype, as we treat more and more based on molecular phenotype that warrants special consideration. And so I think, in those areas, different levels of evidence may be satisfactory. And so in thinking about that, I'd like to just talk a little bit about some real-world evidence and how that's being used to contribute to this area where we'll never have perfect level 1 phase 3 prospective evidence. As you all probably know, the FDA now has a real-world evidence group, the Informed group, led by Sean Kozin. CancerLink has a collaboration with Informed, as does Flatiron. And right now they're looking at a really interesting question. So in patients with HER2-amplified breast cancer that amplify the HER2 gene, that have metastatic disease, there's a treatment that they can benefit from called adotrastuzumab, and it has a toxicity of cardiomyopathy. So it might be reasonable to use it in a patient, but we've never used it in anyone on a clinical trial that has pre-existing heart failure or heart conditions, because they would have been excluded. And so, but faced with the question, is my heart failure a little bad and could it get worse, or am I going to die of breast cancer? Like, you have a rock and a hard place here, some competing, pretty compelling priorities. And so, can you use the aggregated data that you have from data systems and draw meaning from that to understand of patients that had pre-existing heart conditions that were treated with a drug that could potentially cause complications, cardiac complications? How did they do? Can you describe that? And then if you publish that on, less than 100 patients and understood that in fact their heart failure didn't worsen on average, in fact maybe the likelihood of it worsening was similar to how it was in patients that didn't have pre-existing heart conditions, maybe you could use that drug safely. And those are N of 1 kinds of questions. So I think that what you want to do, really, the level of evidence you need depends on many different things, the questions that you're trying to ask. But I think the real-world evidence does have a role now, specifically in those niche questions that we'll never ask on a clinical trial, or no clinical trial will ever be funded. And most importantly, what I think will happen over time is that electronic health records historically have filled this niche of billing. And because of macro and MIPS and other policy issues, they have incremental increasing functionality. I know in our health record, we have a lot of structured data that is cancer specific, that all populates the decision trees that influence your path of treatment. And we'll get there, we'll grow to be that over time, not just my health record, but others too. And when that happens, I think that the level of validity, reproducibility, diminishing inter-rater variability of real-world evidence then improves, and you can use it for more. So I think we're growing in an era where if we build our tools and they, improve our APIs and, share data, that those things will improve over time. So I think the role for it is limited now, but will grow, and I look forward to that time. It'll be useful.
Thanks. I'm going to change the conversation a little bit, but sort of keep it in the same general vein. And I'm going to ask Sanjay to start us off in this, because one of the challenges, it seems to me, is reconciling the notion that we should be practicing N of 1 medicine. So if you take precision, personalized medicine to its logical extreme, you would say that each person would have a uniquely designed therapy regimen based upon their goals, their preferences, their comorbidities, and of course, their personal genetic makeup, their tumor's genetic makeup, and so on. And of course, we are moving in that general direction, slowly but surely, as we do more and more tumor genomic profiling. We're finding out that, each tumor might have a unique vulnerability or a combination of vulnerabilities that requires a specific treatment approach that may not appear in any guideline. It might not ever appear in any guideline or pathway. How do we reconcile, the N of 1 highly personalized precision medicine approach with the application of clinical pathways and guidelines, which by their nature are designed to minimize variations in care,
Right.
when the personalized medicine approach wants to explode variations in care because they want everybody to be assessed as a unique individual. So, Sanjay, you want to handle that one? Start us
A
off.
conundrum indeed. So I came from, obviously, the population health primary care world, where application of guidelines was the gold standard. We would look across our 220 primary care physicians and measure whether they had done the 9 things for every diabetic that was indicated per guideline by U.S. Preventative Task Force. And we would score them. And if they were doing above 70% adherence to those guidelines, they got gold stars. And if they were under 50%, they were informed that they need to improve their attention to these matters. So having been trained in that environment, applying guidelines across 660,000 patients on a weekly basis, measuring the performance of over 400 clinicians, and trying to improve hypertensive care or diabetic care or COPD, really the currency of value was the adherence to the guideline. Now, transitioning into the oncology world, I believe the currency of value is time. It's both time and quality of life. It's a recurrent theme that I'm coming across everywhere. And so what Dr. Pat mentioned about knowing your patient, knowing that they're a musician or that they have a specific hobby or career that will be deeply and drastically affected by a particular therapy, that to me is personalized medicine. But within personalized medicine, we have precision oncology. And precision oncology right now is a growing corpus of evidence, but it is not entirely, it's not a well-defined entity yet. When you say I'm practicing precision oncology, what does that really mean? It is one aspect of a personalized medicine approach, we believe. And yes, there is a tendency to go off-label and off-guideline and off-indication and not within tissue type in order to, one, provide an opportunity for the patient to have more time and a better quality of life, but also we believe in what we're trying to do with the decision support tools as well as the platform and network. We're trying to gather the real-world evidence that will be the substrate for the more rigorous scientific evaluation that will lead to enhanced and improved guidelines. So it's a multidimensional challenge. Without the data, you can't develop the evidence. Without the evidence, you cannot re-engineer and improve clinical care. And all of this takes time, and time is the currency of value.
Yeah. So that's a great segue to a question I wanted to pose to Christian then, which is, doctors, I would suggest, have less time than they've ever had to spend with patients. And they have to undertake more complex decisions and discussions than ever before. And so what's the poor doctor to do? How can the doctor carve out the time to have these conversations? What incentives might need to be adopted in our healthcare system to enable that to occur? Where does this happen in the clinical workflow? Should it even be the doctor who's having these conversations? Should it be another member of the healthcare team who perhaps is highly trained and has the time available? What are your thoughts on that?
Is it to me?
Christian.
Oh, no.
Christian.
Well, that's a great point, Dr. Shilsky, that you bring up. Who in this workflow process is doing it? I mean, what you hope would happen, obviously, would be that you start at the highest level and you work your way down to the most granular pieces that you would need to have that physician insight in. So, from that standpoint, I think you would want to be able to have something where you had a broad, well-educated team that can assist you in doing this. And frankly, as we've seen from both studies, as well as I'm sure everyone's had this from experience, depending on your practice, there are certain people within the practice who are better at communicating with patients than others, and for a lot of different reasons. And so I think that's an important piece of kind of the self-assessment that you want to be able to go through in seeing, okay, what are going to be the different evolving roles that we're going to have interpreting this data. But you brought up a very interesting point, and I thought, and two interesting points I thought you brought up. One is the concept, okay, now, how are we going to support this? I don't mean, I'm really talking about from a reimbursement mechanism. That's not how we're designed right now. We're not designed right now to have that multidisciplinary team, to reimburse for your thought process, and for your use of these type of support tools. That's not how it's working right now. So we're going to have to see how we can support that. And getting back to my point about the smaller practices, the smaller hospitals, the urban, that's going to be a crucial piece for them because of the financial component. I think a second thing that was very interesting that you mentioned was really how are we going to support this? We talk about some of these data systems. I think those of us who have looked at some of the alternative payment models that are coming out that tend to go in this direction. And one of the things we're starting to see is the expense that it takes to simply support these things. And that's not just a financial piece, and I think that's very important. You can have the money. If you simply don't have the people who are able to understand and interpret and apply this data, then you're going to have a real challenge in maximizing its utility.
Yeah, that's a big challenge because if we need, I'm not sure what even to call these folks, but if we need personalized medicine specialists in every healthcare team, how do we pay for those people? How do we generate the revenues in an oncology practice to hire those
and where do you find these people?
Even if they exist.
Yeah, even if they exist.
Right.
Right. Believe it or not, it's one of those problems that can't be solved by
there's
money.
big discussions, I'm sure most people are aware of, as to whether or not the role, for example, of genetic counselors should begin to be expanded to talk more than just about family history and germline risk of developing cancer, but really to have those people be in the front lines of helping to evaluate the tumor genomic profiles, because the understanding of the genomics by physicians is limited. The decision support tools are still limited, and so who is supposed to interpret this information and have that conversation with the patient? Sanjay?
Yeah, I just wanted to add one thing that just came to mind. The clinical workspace today, and over the last 10 to 15 years, is a very complex and inefficient place. And within that complexity and inefficiency, clinicians have had to take on more and more in terms of what they are responsible for, what their actions and those implications of their actions downstream will be in every patient journey. So, one of the things that was a mantra for us when we were training Geisinger was eliminate the unnecessary, the things that waste the clinician's time. One of those things, I would argue, is the need to constantly be up to date with the latest genomic variant and the targeted therapy, and it's just an enormous growing field. And so the second thing after eliminating that need is to delegate to a responsible team, as you just mentioned, a group of experts that multiple clinicians can avail of centrally, and ask for them to be abreast of all of these changes and to help them review a complex patient and a complex decision. A kind of a molecular tumor board or that kind of scenario, a panel of experts, genetic counselor, pharmacogenomicist, multidisciplinary, that would assist a larger community of clinicians offload the intellectual work of keeping abreast of these changes and advances and give them recommendations consultatively so that they focus on the complex decision making at the point of care and not necessarily the ever-evolving science.
And of course, those molecular tumor boards also need an evidence base upon
Yes,
which to work.
absolutely.
Because right now, there are no sort of rules of the road as to how to operate a high-quality molecular tumor board, and a lot of it is based upon, experience, judgment, intuition, this and that person's interpretation of the literature, which, is very complicated. So, Jennifer, I wanted to turn to you for some thoughts about this whole process of developing whatever decision support tool, one is interested in developing, whether it's a genomic tool or clinical trial matching tool, a PRO tool. What's the optimal way to involve patients in this process? Because, I think everybody recognizes the importance of doing so, the valuable perspectives that patients bring. I personally am a little bit concerned that, in many of these types of activities, there are one or two patients who are invited into the discussion, sometimes toward the end of the process, in order to check that box that, physician or patient input was obtained. What's a better way to do it?
I think that's a very legitimate concern. It's been very refreshing to be at this meeting where I feel like patients have been worked in all the way through with lots of different perspectives. So thank you for that to the organizers, because you do go to many events, many advisory boards, conferences where there's sort of that one token patient who's there for check the box that we got some patient input here on this panel. What we've found is, especially in cancer, many different cancers have strong advocacy groups that really can advocate for their community, that have a network of many different patients. So we're working with different groups, people developing tools, research projects to incorporate things into the community in a much broader way. Can you work with a group that could then push your tool out to a panel of people and get multiple different perspectives, different feedback? So I think that's a key way that people can do it. And getting input early. I think a lot of the companies are starting to learn this. We're getting more and more requests for, can you even have patients provide input early on this phase 1 clinical trial? And what would they go on this trial? Why or why not? Are the number of biopsies okay? Or things like that. So we can take that learning and how we're starting to bring patients into those processes into the tool development piece as well.
Great. We have about 10 minutes left. I do want to invite questions and comments from the audience. So if you would like to ask a comment to the panel, please maybe go to a microphone and we'll try to get your question in. While we're waiting to see if we have any questions, it looks like Jen's rushing to the microphone. Go ahead.
I was behind it. Jen Cosenza, I'm with Feinstein Keene, and as a communicator, one of the things, and Jennifer just touched on it, but I've actually thought to ask this question to every single panel up here. Operationally, how can you, and this is something probably for us to figure out, but how do we actually incorporate that patient perspective in a way that is productive to the work that you do, tools that you're trying to develop, or in the actual exam room with the physician? So it's in a way that engages them for what they want to share or gives them the information that they need. And it's authentic to actually inform what you need to go off and make this process better. And I realize that's kind of the whole point of what we're discussing here, but maybe through some anecdotes, there may be an example that's illuminating, like, it seems so simple and it actually helped me to change a course of practice, or we figured out it was a lot harder, and we needed to get data experts in to come up with an algorithm that could help us, get the time to implementation faster.
So, who wants to take a stab at that? But I'm going to look at Deborah because I'm actually curious to know. So when you take off your, pathway developer hat and your journal editor hat and so on, and you just put on your doctor hat and you're sitting there in the room with the patient, how do you actually use all these resources that you are otherwise helping to develop in the clinical encounter?
It's a great question. So to your question more specifically, I'll say I think incorporating part of the patients in the process is really critical, especially for the patient-facing tools. And some of the doctor-facing tools, we use in the room with patients. So Rich, to your question, I see mostly breast cancer. It's about 95% of what I see in the clinic. Yesterday, I saw a patient before I hit the airport with a new stage 2B breast cancer. And, in my health record, it's part of what I do to document, stage, histopathologic characteristics, molecular phenotype, if applicable, if it's accompanied by an FDA-approved actionable analytic and therapeutic intervention. So, for example, ALK in lung cancer, EGFR in lung cancer. HER2, ERPR in breast cancer. So I fill all those things out, and it takes me less than a minute to do all of those things. And I do them when I'm in the room with the patient. I say, okay, I've gotten your history, and let's fill out your information. And then I press a button that says order regimen. If I'm going to give chemotherapy, and a decision support system pops up with the therapies that are within the pathway, and then those that would be exceptions. And if I'm going to be a chef about it and really create something new and have a variation from the pathway, I then have to actually take extra steps to put in evidence for it to have support. Because hopefully all the decisions that we're making are evidence-based to some extent, or at least have some reasonable justification, all 100% of them, even though only, we have the goal of 80% on pathways. And so it takes me less than a minute to order their chemotherapy, and partnered with that, actually, which has been a new change. So I do that in the room with the patient as I order for them to have a chemotherapy teaching session. And so I'll say 10 years ago, chemotherapy teaching was something that 10 patients did at a time with a nurse. Now we have one patient do their chemotherapy teaching session with a caregiver, and usually a nurse practitioner, advanced practice provider. And so they get an hour where they talk about each therapy, the toxicities of the therapy, how we're planning on managing the toxicities. Again, because we believe that I'm not the holy grail of oncologic knowledge. I have a care team. My patient needs to know that they interact with that team. And there's so much information asymmetry between doctors and patients that we need to be able to translate some of that. And if we can empower patients to better manage their disease and interact with us as necessary, they actually do a much better job of doing that. So my interaction with patients, I'll have to say that quality is very good. So I spend probably 2 to 3 minutes in front of the computer in each patient encounter. And take care of all of my documentation and regimens then. And the nice thing about that then is I'm a busy doctor when I'm in clinic, and I don't have stuff to do later. I finish my work when I'm sitting there in the room with the patient. So the last thing I'll say about all of these things is really, in my opinion, oncology is behind other subspecialties when it comes to decision support. And we actually need it most, again, because I think that there always exists information asymmetry between doctors and patients, but given our paradigm shift to treating on molecular phenotype and complexity of decision making, that gap is much greater in oncology than in any other specialty. And so I would say as you pursue these pilot programs, as you pursue empowering patients to have decision support tools and empowering doctors to make decisions, and anything to nudge or facilitate good care decisions, I would strongly encourage you to publish your work. While it's my strong interest that you publish it in JCO-CCI, really anywhere would be fine. But
I didn't put her up to that.
But what we lack is optimal sharing of these programs, because like many of us in medicine, we're dependent upon corporate partners, and in the business world, these things aren't always published as health services research. People kind of run pilots and then they may choose not to publish them, and that doesn't serve the greater good. And then you hear stories like Watson's AI platform or other things that have gone awry in certain situations, and people have reluctance to engage in this space where we tremendously need to make progress. And so I'll just say we will only make progress by sharing information. And so when you begin these programs and venture into these pilots and begin in this space, I would strongly encourage you to publish in this space. And I reach out to a lot of folks to do that. So please think about that. We all need to get better faster. It's mutually beneficial.
Jennifer?
I want to stress one thing that Deborah said, which is the importance of caregivers in the process. And very often the caregiver is extremely influential, both in being the person who is doing the homework and doing the research and bringing that back to help present to the patient, but also in the decision-making itself. And that person plays a really important role, and having a better relationship with the caregivers, incorporating how the caregivers might use many of these tools, that can be really important in this whole process too. Also, I think it's important that we remember the entire spectrum of patients. I think in a lot of things like this, we end up with the highly health literate, the patients that understand the difference between the mutations. Lung cancer clearly is a huge, there's very different populations with very different socioeconomic situations, rural populations. You know, we see patients who are very activated. I had a call this week about, I saw this data at ASCO and I want to get this drug and get it covered. Can I get that? But we also get a huge number of patients that are like, I'm just going to do what my oncologist tells me to do.
Yeah.
So I want to get your question in, and then I'm going to maybe ask one final question to the panel, but please go ahead.
Hi, Susan Thornton, Cutaneous Lymphoma Foundation. And I, just as a rare patient community, I want to say thank you for actually inviting me and allowing me to be here in the conversation. But I would also say, as a suggestion, there are a lot of patient organizations that are small like mine that may target a very specific area in oncology. We have the trust and the respect of our patient communities. And I come from a business background. I was in healthcare EMRs before they actually became EMRs. So I come with a little different advantage in running an organization. So I see these kinds of events as very important. But there are a lot of other organizations that can't get here, don't know about it. And I think there has to be a way for us, again, to be able to share these kinds of opportunities. So those of us that are dealing directly with the patient community, that we can become an engaged partner as part of this, and being able to bring our patient community's focus in maybe some specific areas that don't get addressed in the broader oncology. We're not breast cancer, we're not prostate, we have a broad spectrum, it's chronic, it can be aggressive. So, I think that there's a way to do better communications and connections within the patient organization community as well, so that we can participate and bring our expertise to the table. Saying that.
Great, thanks. So that actually is a good segue to, I guess, the last question we'll have time for the panel to address, which, as I mentioned at the beginning, we have all sorts of decision aids out there now. Some are developed by not-for-profit entities, some of them are developed by commercial entities. And I'm so glad you brought up the point, Deborah, about publishing your experience, because it's sort of a fundamental question to me as a researcher over many years is, how do you know if any of these things are any good? They're all put out there. They're all in some way, shape, or form marketed or advocated for or proposed as something that somehow we should intuitively accept as being useful or beneficial or improving the quality of care. But very few of them are ever subjected to any sort of more rigorous evaluation. So how do we know if they're any good? And if we don't know, what should we do to figure that out?
Are we going down the line?
Well, we'll start with you.
Yeah, it's a great question. And I guess first I would say that it is, even though I sit up here as a representative of the Blue Cross Blue Shield Association and certainly work for, an association of traditional payers, we all know that the way in which insurance has historically played out is changing, and providers and provider groups are taking on more and more risk. And as we're in those situations, I think it's absolutely essential that we not only put tools out there, but as we said, put tools out there that we really know are not only going to improve outcomes for patients, but are also going to allow physician practices to actually be able to continue to run and operate in a way that works financially. And so I think it all is really important, and there probably needs to be, and maybe there are, people down the panel will know this better than me, just like we evaluate clinical trials in a standardized way, there's got to be some standardized way in which we're evaluating these tools, at least the tools that are being deployed and looked at across health systems, right? Certainly individual health systems that develop their own tools and use them internally are going to have their own quality metrics and financial metrics for using them, but certainly these things that are being deployed across multiple systems, and then potentially even pooling data from multiple systems to be utilized more broadly, we really do need some standardized way in which we can evaluate it, and I don't know if we have that or not.
Yeah, so, again, as I said before, I think that these systems need to be evaluated and published. And I'll say that in cancer care, we have no lack of genomic-specific, molecular phenotype-based trials, chemotherapeutic intervention trials that get published. And obviously, those trials are well-funded, and there's lots of incentive to do that. The driver for good health services research, especially that's qualitative in oncology, is far less. And actually, that's one of the reasons I loved Ethan Bosch's presentation on PROs that got a plenary session at ASCO, because I feel like, getting health services research out there in the public space is so critical, because we do all want the next new novel therapeutic intervention. So excited to see about the TRK fusion inhibitor in developmental therapeutics. We all want to see the new latest and greatest thing. But, when we've run pilots in my large practice, alternative payment model pilots, to look at reductions in cost and improvements in care delivery, what we found actually is acute care management, average length of stay, hospitalizations are really low-hanging fruit, which has a lot more to do with our care delivery infrastructure than it does the latest and greatest new drug. It has a little bit to do with the latest and greatest new drug, but it a lot has to do with how we manage triage, how we think about infrastructure support, our teams of care delivery, patient navigation, providing information about death and dying, having advanced directives clearly articulated, educating patients on their care and how to manage their symptoms regarding their treatment choices. So a lot of other things that really are health services that there's not going to be a tremendous financial incentive to invest in. And it's hard because we're all going to put up a lot of capital to try to make improvements in these areas with a very limited amount of knowledge. And so, the more information we can put out there, even process workflow, descriptives, operational opportunities, there's a real appetite for that. And so that's my nudge to get it out there. And we would be happy to see you submit to our journal.
Sanjay?
Yes, I think there's a number of good frameworks. And one of the journals that I read is the American Medical Informatics Association. And they're focused on analytics and clinical decision support systems, the deployment, the measurement of impact around physician productivity, patient safety, as well as adhering to guidelines. We can use that framework now in oncology, begin to learn how other studies were conducted in that general space of medicine, and I think that will give us the scientific rigor and framework we need to apply to our own scientific field.
Christian, any thoughts?
Dr. Schilsky, just not to be too contrarian here, but I wouldn't want the perfect to be the enemy of the good either. So I think particularly when we start to look at some of these tools and how we're going to be using them, we also need to rely a little bit on the market. I'm always amazed when things come out and someone comes by and tells us this is the best thing they've ever seen, and it's amazing how over time, like water, we go in the direction that seems to work. And that's not to say we don't do this, we don't do our studies, we don't do our publishing, because I think that's key to be able to get the information out. But I just think it's something that, particularly in this situation, we want to make sure that the perfect is not the enemy of the, hey, that's pretty good.
Jennifer, we'll give you the last word on this.
All right. I mean, I think that evaluation is key in understanding whether the tools work. That doesn't always have to be the highest level scientific evidence, as we talked about with real-world evidence earlier, to Christian's point. But one of the things we've seen is that, your going-in assumptions are not always correct, right? Most of us in the research community recognize that. Even with the clinical trial matching tool, we have been evaluating by calling patients back 2 or 3 weeks later and saying, do you need anything else? Where are you in the journey? What's happening? And we've learned a lot of really interesting things where we were completely wrong. We thought people would be looking for trials at the point that they needed a trial. That actually is not true. Most of the people who are using it are on their first-line care and wondering what happens if they recur. So they're looking much earlier in the journey than we thought. And so that constant evaluation leads to process improvement, and I think it's critical.
It's a great point. So I think we're going to have to call it a wrap. I want to thank all the panel members for a great discussion. Thanks to those of you in the audience who participated. And I guess we'll get on to the next session. Thanks.